All right, so we're going to start with the rotator cuff muscles today, and I'm sure most of you have heard about the rotator cuffs at some point because they're injured so frequently. When you hear about people, needing a rotator cuff surgery, this is super common. So the rotator cuffs, there's 4 of them. There's these 4 muscles that the first initial is SITS. So sometimes you'll see the rotator cuffs called the sits muscles. It's Supraspinatus, Infraspinatus, teres minor, and subscapularis. The thing about these rotator cuff muscles is that they both have actions of moving the glenohumeral shoulder joint, as well as they're all stabilizers of the glenohumeral joint. So this glenohumeral joint is the most movable joint in the entire body. There's only 2 ball and socket joints, the hip and the shoulder. And of those 2 ball and socket joints, this one allows the most movement. Why do you think this one is designed for so much movement? Wider range of motion with our arms, excellent. And why do we want that?
Continue to live and be able to move things around and manipulate the environment.
Excellent. Move things around, manipulate the environment. So we need to be able to get our hands in all kind of positions to do things, right? So this joint is extremely movable. It's very good at helping us achieve that. However, there's always an inverse relationship and a risk. So the more movement you have, the more risk there is to damage to that joint. So there's, between mobility and stability. And so with this great movement, comes at a cost. And so these rotator cuffs, it's their job to also help hold on and stabilize. You can see from this model what's kind of in like a cream color or beige color. These are the ligaments. So there are also ligaments from bone to bone helping stabilize this joint. But the tendons of these rotator cuffs, which you can see on the screen share, the gray part of these muscles is where they end. The muscle belly goes into the tendons. And those tendons of rotator cuffs reach around and also help stabilize. But with repetitive motions and extreme motions, particularly external rotation at the same time as abduction, this is really hard on that joint. And so sports or things that require this a lot are really taxing to the rotator cuff. So what are some sports that do this kind of motion a lot? Baseball, tennis, excellent. And so which position on the baseball team is at most risk for this? The pitcher, right? So they limit the pitch count, right? But the toll on a professional pitcher is tremendous, right? So they can have rotator cuff injuries. Now, you can also have like a blunt force trauma, right? That pulls those tendons past how much they can stretch. And so what kind of sports folks are using their shoulders where they're slammed into a lot, and that can also tear them? Football, excellent. Yeah, so I mean, these are just some examples of frequent rotator cuff injuries, though other folks can get them too. The tears in the rotator cuffs, just a preview. We can have different degree of tear, just like we can have different degree of, strains and sprains. We could have like a partial tear that might even heal itself, but sometimes one or more of these tendons can come completely off of the bone, which is called an avulsion, starting with the A, or they can tear in the middle. And so that's, more often when we're looking at when people need surgical intervention. So it's really common rotator cuff surgeries to have to, repair these tendons. Yep.
So when it does that, it can't feel on the bone.
Yeah, if it completely tears or completely rips off, it won't heal on its own at that point. Yeah, so they might, if it's intact enough, they might, you know, basically staple it back into place on the bone. And sometimes that works and sometimes it doesn't. I can tell you a disgusting story if you like. You can you can leave the room if you don't want a disgusting story. I can tell the story with more or less blood, but I had a kitchen accident where I cut this tendon all the way to my bone, and there's an artery there, which is why the story is bloody. There's a nerve there, and there's a tendon there, which lets you do this. And so with that tendon completely severed, there's no way that can heal. So they first tried just reattaching it to my bone. That was surgery number 1. And in physical therapy, that popped right back off. So then they had to take a tendon from my foot and put it in there. And now it's completely healed. Yeah. So that is obviously a different area of the body, but the same type of thing where they'll try to, you know, first reattach it. Sometimes they can try to sew it back together, but sometimes they need to either with an artificial tendon replacement or a tendon from your own body, try to replace it. Yep.
Do you feel the difference in your foot if they took some of your tendon from there?
Yeah, that's a great question. Do I feel a difference in my foot? They took extensor tendon from one of my left toes, and I do not notice it on a day-to-day basis if I wear shoes that my body likes. That's why I'm always in my running shoes. But it's hard to say because my feet got more particular after pregnancy. And so I don't know how much of that is for pregnancy, which is common, and how much of that is from missing a tendon. Yeah. But I think they said that that particular tendon, the tendons around it would help lift the toes, and it's for one of the smaller toes, and it's not one of the major balancing toes. And I don't really notice it in my day-to-day at all. Yeah. It took a lot of PT. You know, I got to go to the Harborview Hand Clinic, which is a really, really cool state-of-the-art clinic. They're like totally rebuilding bionic hands for all kind of conditions, and very neat. They have a lot of cool equipment there. But anyway, that's just a story about these kind of tendon things. But back to the rotator cuff. There's these 4 rotator cuffs, and I find it easier in general when we're learning these muscle groups to try to kind of group together in your mind like what they have in common and what they have different, which we'll do as we study these. I want to point out right away the one that might trip you up the most is you can see teres minor in this group. We want to keep teres minor and teres major in our minds, right, separate. And so teres major, remember, is a direct or complete synergist with the lats. And we know that we're in major trouble if we're handcuffed is the cheesy way to remember that. But those are all the positions that that muscle can do. So we keep teres major with the lats as one of the handcuff muscles. That's one of its nicknames. Questions so far? All right, so let's dive a little deeper with these muscles then. As always, I try to make a lot of massage connections as we go, but we will certainly spend a lot more time in the massage lab with these as we really get some more treatment techniques and as we get to, you know, working with trigger points and so forth. But you probably noticed even with just 1 day and 15 minutes of Swedish massage that you maybe feel a little more confident in the areas where you've started to study those muscles already. So yeah, all right. So we're going to start with supraspinatus. So supra is like superior. Spinatus refers to the spine of the scapula. So this is our friend that, here's our spine of the scapula, posterior view of the scapula. This is our friend that lives right up in here in this supraspinous fossa of the scapula. And what is this muscle deep to? And it's deep to trapezius. Yeah, good. Yeah, deep to trapezius. So something cool about this muscle, we can see, you know, where it attaches over here on the greater tubercle, but something cool that you can't see too well on a drawing, which is why we want to also look at models all the time, is that there's actually this tunnel between, I'm going to show you guys in the classroom too. There's this tunnel under the acromion process. So the supraspinatus actually travels through this tunnel. So it's way under the bone when it attaches, right? So, I mean, we can't feel this part of it, but we can massage this part of it. I find the best way to palpate and massage this is to really soften up the traps and then really palpate the spina of the scapula, and then just feel just anterior to it. And then when you scoop out this fossa, which you can really do, then you're in supraspinatus. Yes. Move this? Sure. There's not much to see with the mask on. All right, so let's break this baby down. So as you know, I like to start with origin and then insertion because that all makes sense of the actions. We're going to go with standard protocol here, which is that the origin is in red, the O, and that's not a very good red. I don't know where the red went. We have like orange or a brown. So, okay. So our origin, our O, is the supraspinous fossa of the scapula. Whoops, that was messy. This thing's hard to draw with. I called this out last time, but I really love this feature of the trail guide where they always have at least one picture of the bone with the actual origins and insertions shaded. And what I love about that is you can see where exactly does it attach, because as you can see in a case like this, the origin is this entire, you know, supraspinous fossa, whereas in other cases, sometimes we're talking about a very small part of a bony landmark that we're attaching to. And when you see something attached to like a big part of the bone directly, we know that it's the deepest muscle in that area. We know that it's pulling right onto the bone itself. So the bone has this living tissue directly connected to it called periosteum. And so we've got that muscle just directly onto that. That's part of the reason, and that is a richly innervated tissue. That means there's a lot of nerves, there's a lot of blood supply, and that's part of why the deeper muscles can be more tender. They can also be more tender because they often act like postural muscles, so they're often firing more. Another reason, and those of you who like to work out, this might interest you, is that, you know, a lot of folks who work out kind of slam on their superficial muscles and they sometimes neglect the deeper muscles. There's a lot of trends nowadays that try to work against that and do, you know, full body movements and, you know, things like Pilates as well that kind of really get in there. Yeah, sometimes these deeper muscles are not addressed as well. Yes?
I was in a different place, but I heard you say tender. That could be why they're not tender. What was the beginning part?
I kind of gave two reasons at that point. One is that those muscles are attaching directly to the periosteum of the bone, and that is a living tissue that has a big nerve supply. It's innervated, and it has a big blood supply. And that being richly innervated and that muscle constantly tugging on it can be one reason. And also because those deeper muscles often can act in a more postural way. So they're often firing more with less rest. Meaning it has its own a good nerve supply. Yep, question, comment?
So is it not the muscle isn't connected to the bone, but the periosteum?
Great question. So the tendon weaves directly into that periosteum. So yeah, makes sense.
Well, it is obviously connected to the landmark on the bone.
Yep.
But
through the periosteum, right? Exactly. Periosteum, great question, is the living tissue layer that is on top of the bone. And so we'll talk about this more when we get to the skeletal system and anatomy. But I think sometimes because when we look at bones, we're either looking at plastic models of bones or dead bones, that we get this false sense of them being this dead, just calcium and other mineral deposits. In the body, the bone is very much alive and it has blood going through it. It's constantly remodeling. It has this living tissue as part of it, on top of it, that has nerves and blood vessels. And so it's this living tissue. And so the muscle through the tendon weaves directly right into that. That's how it attaches, right? So like in a surgery, they'd have to like drill and staple and things like that. But in the body, it's weaved together. Yeah. Questions? The tendon, excellent. The tendon is woven through the muscle and the tendon is woven into the bone. Yeah. Yeah.
So would they have to have into the muscle too to fix things? Is it the tendon if they're ripped?
It depends where it's ripped. You know, is it more just the tendon? Is it all the way into the muscle? The muscle heals a lot better than the tendon. And this is going to come up for you clinically, depending on what your clients come see you for, but it's definitely going to come up for you. And it's part of your problem solving when you're thinking like, what can you do here? The muscle belly has a very rich blood supply. And because it has a very rich blood supply, it can heal a lot faster. Tendons and ligaments have almost no blood supply. And that's why they heal very slowly and poorly.
Plus they don't have the same elasticity, right? Like they're overstretched. They're overstretched type of thing.
Yep, they are elastic, but only to a point. And if you overstretch it, you know, so bad, too sad, right? Yeah. All right, so, yep.
There's exercises to help with tendons too.
In what regard?
Like isometric and eccentric exercises. So it's not so sad.
I mean, you can help with them, but they don't have a blood supply. And if they were just in a minor injury, you can help them more. But if they were fully torn or fully overstretched, that's harder. But you can also do preventative medicine by doing the kind of exercises that are good for your muscles and tendons. Yeah. Which people are a lot smarter about now. All right, greater tubercle of the humerus is the insertion. And so here we are on the bottom diagram. It's this blue in the front. So your trail guide has a couple great pictures where they really show you, you know, if you're comparing the insertion of all the rotator cuffs, exactly where they are. And I'm looking at an older edition, 4th edition, but there's a picture of the hand reaching over, showing you where those originate. That's another nice view. I'm on an older edition, page 79, but it's a hand reaching over the greater and lesser tubercles and shows you where the SITS attaches. It's on this picture too. The other one just gives you a different angle of it. Somebody on the new edition, find that and call that page number out, please. 6th edition is on page 80. Thank you. I think we probably have some 5th editions here too. All right, so our supraspinatus is our only, we're gonna start looking at actions, okay, folks? So our supraspinatus is our only rotator cuff that goes straight over the top. So if you go straight over the top and you shorten that distance, what movement can happen to the arm? Abduction, right? It's a very strong abductor. All the other rotator cuffs either angle in front or behind that arm. So they're also going to be able to rotate, right? So this is our only one straight up. It's not going to rotate. Does that make sense? They all also stabilize. So pretty straightforward on supra. We go straight above. It's the strong abductor of the shoulder. What muscle do we already know that's a strong abductor of the shoulder? Deltoids, beautiful. So we can see that, you know, the deltoids have, especially the medial deltoid, whew, those ligaments are blocking that, has a similar angle, right? Where it's coming up over the top. And so when those fibers shorten, it can pull like that. So those two can both abduct the deltoid, and the supraspinatus can both abduct the shoulder. So what do we call them in that movement of abduction? Synergist, beautiful. Questions? You guys are on it. All right, let's move on to the next one. If I can stop my drawing thing, because I can't drive when I'm in that mode. Thank you. All right, so infraspinatus has a similar naming. Infra is like inferior, so below. Spinous refers to our spine of the scapula. So this one is located below the spine of the scapula. Let's start with O, then the I, then the A. So the origin, infraspinous fossa of the scapula. And we can see with the shaded area that it's like supraspinatus, a big part of this fossa. So the muscle is weaving directly into the periosteum on the bone in this big area. Now, you guys have started to feel this muscle already, and you've probably noticed that it's a pretty kind of bulky muscle, right, on folks? Let's look at the insertion. The insertion is also the greater tubercle of the humerus. And the muscles, you know, tend to, you know, kind of attach next to each other unless they're sharing a tendon. So here we have right behind supraspinatus, the insertion of infraspinatus. And if we look at these fibers, I'm going to now draw on the top diagram in pink. If we look at these fibers, they are crossing on an angle behind the shoulder. So we now want to imagine if we were playing tug of war or in some way shorten the distance between this infraspinous fossa and the greater tubercle on a ball and socket joint. If we shorten from behind, what kind of movements are possible? We could do this, pulling it this way. Can you see that? What's that called? Adduction, beautiful. We can pull backwards in a rotational motion. What would that be called? Lateral rotation, beautiful. Can you all see that? I'm guessing yes, because so many people said it, beautiful. And then we also stabilize, right? So they share that stabilization function. Excellent, beautiful work, folks. There's a lot of muscles that cross from the general midline across the back direction. So those are all going to be adductors. So there's a lot of adductors. Beautiful work, everyone. So that's our motions. And are there any questions? If not, we'll move on to the next ones. I guess I'll just point out one more thing as I was drawing these little fibers. We got all these kind of triangular, convergent, layered fibers. So, you know, I like to call out massage palpation implications. And I just want to call out on this one that no matter how relaxed the infraspinatus is, it can feel sort of thick and bulky because it has this kind of layered arrangement. That's not to say that you shouldn't massage it because it often is also tight. but just that it is going to feel kind of like a thick muscle in there. Very, very palpable. Yes. Very similar. Yep. Where it's going to feel bulky. Yep. Yep. And sometimes with those bulky ones, you kind of have to really spend a special attention as you work through those layers, and petrissage is excellent for that.
There's a lot of attachments on the greater tubercle.
There are, yes. And as you can see, you know, they do a good job here of showing you how they're kind of, you know, it's these tendons sort of wrapping around, and that's how they stabilize all the way from this greater tubercle. So, you know, like if I was like playing piano, or actually many instruments, you know, with the different fingering, you'd, you know, put your hand down on all these greater tubercles and then our lesser tubercle, and they all wrap around like that. So they help stabilize. If we're looking at all four. It is so beautiful, such a beautiful, elegant design. I'm in love with the design of the shoulder. It's amazing. I love the shoulder. All right, cool. Let's take a look at teres minor. We'll start with the O, then the I, then the A. Our origin, O, of the teres minor is the upper 2/3 of the lateral border of the scapula. And what we always want to do here is really make sense of what these words mean. It's useful to palpate on yourself or someone else, look at a diagram, you know, and so we're talking about upper 2/3, so the superior 2/3 of the lateral border of the scapula. Lateral is on the armpit side. And there is our origin. Now, what muscle have we already studied that originates on the inferior aspect of the lateral border? Teres major. Fantastic. You guys are rocking this. So this is just a mnemonic. Obviously, this is not how the body really works, but if you want to help memorize major and minor, there's a couple cases where this is true. The major, you know, you can think of it sort of because it's bigger, settling down to the bottom, and the minor, because it's lighter, floats to the top. So we have our major down below and our minor up above. Now here's something, let's go, sorry, let's take this step at a time. Let's look at our insertion. It is a greater tubercle of the humerus, like the last three. And this is one of those cases where, you know, I was saying, if we're studying a group, try to put the same things or similar things in your mind together. And here we have these, the first three that we looked at, all inserting on the greater tubercle. And here we are, this part in the back of the greater tubercle. And just as a refresher, that's the lateral bump on the humerus. You can see it's a very big prominence. So we're able to share this with three muscles. And we were to draw these fibers so that we can think about if we shorten the distance. These fibers are coming from behind the shoulder, very similar angle to infraspinatus. And because it is almost the exact same angle, if we shorten that distance, it's going to do the exact same jobs. So infraspinatus and teres minor are complete synergists. So if we shorten that distance between those 2 points from behind, let me try to get my little model here. If we shorten that distance from here to here, we can bring the arm closer to the body, which is what? A deduction. Fantastic. And we can pull backwards like so. What's that? Lateral rotation. Fantastic. Now here's kind of where I want to revisit, because there could be a lot of test questions like this, and also just like if you're doing pin and stretch, to keep major and minor clear in your head and to not conflate them or mix them up together. The big difference between major and minor, because you may be thinking, well, isn't that the same angle? Wouldn't they do the same thing? Well, major attaches, that arm's on backwards, okay. Major attaches directly in the back, and so it can laterally rotate, whereas minor, and I tried to emphasize this when we sculpted it last week, weaves around through the front.
It's major.
Major. Major weaves around the front. And that's how major can medially rotate by being in the front, whereas minor attaches in the back and laterally rotates. So that's how they're not really, they like look like they're on the same angle, but the one weaves in front, major, and so it medially rotates. Does that make sense? Are there questions about it? And that's how major is a direct complete synergist with lats, whereas minor is a direct complete synergist with infraspinatus. Make sense? All right, so that's 3 out of our 4 rotators. We got one more. It's a little unique. It'll make more sense possibly on a model than a drawing, so we will try to help make sure you understand this. Starting with origin O is the subscapular fossa. Sub, like submarine, is like below. And in this case, what that means is the whole fossa on the anterior surface of the scapula. And again, with the shaded picture, you can see that it's actually a very big origin. And so if we were looking at a scapula, we would want to look at the anterior side, and then it's originating on this whole front side. Now, if we were to put this on a human or a model, we have, if we were to do that and the muscle belly is right here, and we were to then put this on a model, we could see that that muscle would be sandwiched between this bone and the ribs, right? So it's very, very, very deep. And the part that's mostly sandwiched, we cannot palpate, but there's ways that we can feel the edges of it. Yep.
So there's no muscle between the subscapular and the rib. That would be serrated. Serrated.
In a different, in a mostly different spot though. So the serratus is mostly here. So there's a part where it's the only thing, right? And then the serratus is over here. So there's part of it there. Yeah. Great questions.
Serratus holds it to the scapula to the rib cage.
Yes, that's one of its jobs. Yeah.
And it originates from the medial border of the scapula
Yes.
into the rib.
Yes. And we'll study it another day, so I don't want to like confuse this, right? So let's, but it is a cool muscle. Yeah, yeah. Just
That's when it pops out on the front, too.
Yeah, I'm glad you're thinking about it. I'm just going to try to not confuse people with too much. But thanks for the great questions and ideas, everybody. All right, so our insertion, I'm shading in blue right now, is the lesser tubercle of the humerus. And the tubercles, right, are these the bumps. And so here's a great anterior drawing as a reminder, a refresher. Lesser tubercle is the medial bump, and the greater tubercle is the bigger lateral bump. And then what's very palpable between them, if you want to remind yourself on your own body, we have this intertubercular groove where the biceps tendon goes through, is very tender. Not a great place to massage, but it is a great place if you alternately, laterally, and medially rotate your arm to help feel like which bump is which. I find that the intertubercular groove being indented and tender is a good marker, right? So if you find that groove and the bump medial to it is your lesser tubercle, and the bump lateral to it, which is a big bump, is your greater tubercle. I personally find that these muscles, these particular muscles, are better massaged on their bellies and on their origins. And I don't do a lot right here on the insertions with these, other than with the fascia and with the deltoid. All right, so our fibers here again, right? There's this whole part that's super deep, and we're not really going to get to palpate that super deep part well, but there's this little part sort of near the axilla border that later on, it's not the first place I like to teach how to massage, it's a little more advanced, but there is a way to get around that border and to palpate basically right up in here. But we have some big muscles, right, to contend with to do that. And it's very tender on folks. So not the first thing we do.
Well, Elizabeth did that scapular pull. It feels really weird.
Yeah.
She did it on me too. So it felt like it wasn't supposed to happen.
It's harder to do than to like.
Yeah.
Yeah. It's hard, and I'll have to say it's not like the first place you have to get to in Swedish massage, right? We can come back to it for sure. Yes.
It's like you're ripping it off.
I feel like it's.
Well,
I just have to say, massaging different bodies is like a totally different animal, like every time. Sometimes.
Yep. Yep.
And there's
But the
things
more-
that you can find, the things that are harder to find.
Yep. Yep. It's true. It's true, but the more people you massage and the more you know your kinesiology, even though there's those differences, you'll be able to find your way faster and faster. Yeah.
This is like a blueprint, basically. Something like that.
Yep. Yep. And in addition to, you know, different amounts of adipose tissue and muscle and adhesions and blockages and all those things, we also have straight up anatomical variation. So some people have straight up different size bones, different size projections. I was hanging out with a massage therapist friend last night, and she said that she had a client last night that had the smallest scapula she's ever seen. And she was like, little baby scapula. So there's straight up differences even in the bones. But you'll feel it more and more. All right, so if we were to pull, you know, shorten the distance between, you know, this scapular, subscapular fossa and this lesser tubercle of the humerus, you know, shortening between here and here, can you see that that would medially rotate the shoulder? Yeah, cool. So I think, you know, these are pretty straightforward in their pull directions, as long as you remember, you know, that the teres minor is going directly behind. So it's almost exact same fiber direction as infraspinatus compared to teres major, which weaves up in the front. And then, you know, if you can really picture that supraspinatus goes right up over the top, it does not angle in the front or the back. So it is our strong abductor. Can you picture all the other movements though? Yep, question?
Yes, so for the scapular.
Yep.
It's kind of curved and around the rib and then
Exactly. Yeah, and I think I would highly recommend you check out the life-size articulated models as well as the life-size scapular models, and you know, you can see that there's actually a very big curve in this, right? And that very big curve is to go around the ribs, another part of the brilliant design, right? Yeah, it's just beautiful, right? I'm not gonna throw it though. All right, that's our wonderful rotator cuffs. Any questions? All right, we'll just take a little quick tour here at some other angles to get a view here. So here we are looking down from the top of a human, or as if they were laying supine on a massage table. And I think this is a cool view for like when the person is supine on a massage table. you know, how we can really get into these tissues. And this view of the axilla, I think, is a great view of, you know, part of subscapularis. But of course, you can see here we've got the big lats, you know, forming the big posterior wall of your axilla. And then we've got the pecs forming the big anterior wall. And so those are kind of our, you know, our sort of triangle outlining that area. Yeah, so this is a great picture. Thank you for calling that out, Anna. I'm going to use purple right now. So
Dovetail.
yeah, so the little serrati, you know, attaching to the ribs. We'll study them later, but it is useful to really picture these muscles in relationship to each other. So gets used in what?
Massage.
Oh yeah,
That's probably the one that would help you the most. I would guess.
you think?
To reach over there now, so you're not like this.
Oh yeah, yeah, yeah. And our packs, right, for that as well. Yes, it's a good thing to bring up, right? So of course, depending on the amount of breast tissue and the amount of adipose tissue in this area, right? Sometimes part of that is covered, and obviously we don't touch breast tissue. When we massage muscles that are, you know, closer to breast tissue, we'll learn some more techniques. One of which is to have the client side lying. So if the client was to lie on this side of their body, some of the breast tissue with gravity would fall down to the table, as would some of the adipose tissue, and that would free up some more of this area. So that's one technique. Yes.
Do you watch clients turn sidelines often? Because I don't think I've ever done that before.
Yeah, side lying is a super useful, underutilized technique, and we're definitely going to learn different things in side lying. So yes, there's a lot of great things you can do side lying.
But you do that in
I do. Not every single massage, but I definitely use it. Yeah. It's a great position. Here we have, you know, pretty straightforward on the supraspinatus, although on this top picture, you can see how it goes under the acromion process tunnel, which is pretty cool. And on this lower picture, right, we all can feel the big old infraspinatus, right? It's lumpy, yeah, it's lumpy. Exactly. Thanks for using those words. And that's why, like I mentioned, right, that it kind of has that sort of feathered, layered, sort of like the deltoids. And so part of the reason I mentioned it is because sometimes you might think a certain muscle is like tighter than it is, and it might be sort of the way that muscle is designed. But it can be lumpy for sure. This is a kind of this is a tricky angle, but actually I'm going to call this out because, you know, when we study teres minor as having the origin of the superior 2/3 of the scapula, a lateral border of the scapula, it makes it seem like it's really big, right? But when we palpate teres minor, in reality, what it feels like, and I'm going to do this in purple right now on the upper right drawing, is it's tucked way up high in the axilla. So if we palpate and massage a human on the lower border, we can feel a tight muscle right there is major, but to feel minor is way up, like you're almost up in the axilla, and it feels, it's not wide, but it can feel very tight. And it's very useful to massage there, even if you can't like sort of grab it as much as you can some of the other muscles. And we will take time to palpate those. Actually, why don't we take a little palpation break right now? I'm going to pause the recording. All right, so next ones we're going to look at are the rhomboids. And, you know, they really act exactly as one muscle. So almost always people just say the rhomboids. They don't usually really separate minor and major, but just for this sort of mental exercise that Trail Guide has them separated, we'll do that. This is the same kind of deal with the that we looked at with major and minor, though, with that little mnemonic that the minor one is lighter and floats, and the heavier one is the major and it sinks. So major is below the minor. Here we have muscles that go between the medial border of the scapula and the spinous processes, which are the parts that stick out on the vertebra. So we've got these muscles that go between here and here. It's hard to do it. My hand's going to block it. But they go between here and here. Yeah, that is not easy to do with a hand model. And they angle, if you were to put the left ones and the right ones at the same time, they would angle like so, like an evergreen tree. And that fiber direction is important to be able to palpate them, to be able to distinguish them from traps, and also just to understand some of their movements. So let's take a more detailed look at them. Origin, insertion, action. So the rhomboids, being in this middle of the spine, what do they look like they're deep to right there? Traps. Excellent. So these are deep to the trapezius, but in this region, the traps are very thin. So it's very easy to palpate right through the traps, right into the rhomboids. So let's take a look at their O, the A, the A to make sense of them. Origin in red. Again, really people often group these two. So you could look at this as one big origin, but for the sake of how Trail Guide has them separated, we're basically looking at the spinous processes here. Now, higher up is minor, so starting all the way from C7 and T1, and then major is then from T2 to T5. So as a reminder, because we haven't gone that deep into the spine yet, the C, what does that stand for? Cervical, excellent, right? So we count from the top down. 1, 2, 3, 4, 5, 6, 7. So, and if you feel on yourself, it's 7. C7 is the one that sticks out a lot. So that's as high up as the rhomboids attach. And then you can count down from there, T1, 2, 3, 4, 5. That's as low as the rhomboids get. And then they angle down from there. On your drawings, you know, the one that looks kind of round on the top is actually C1. So count from there. That is a vertebra. And if you're looking at a good model, like a big model, you'll see that C1 is a round disc. So that's what that picture is trying to indicate. We'll study the spine in detail next, but just a preview as far as those of you looking at that drawing, trying to make sense of it. So if I was to, you know, draw that origin, our higher one is this on the bottom picture is minor spinous process, the part that sticks out, C7, T1. If you go ahead and palpate that on yourself, C7 sticks out. And then you go down one from there is T1, right? And the spinous processes stick out. And then there's an indentation between them. Our insertions in blue, oh, sorry, I stopped too soon. And then going down to major, we continue down the spinous processes of T2. Oh, sorry, I should do that on the upper picture. T2, T3, C4, and C5. And you might notice from a drawing or palpating yourself or a client that these are not equidistant. There's a bigger distance between some and others, and that's okay. Part of the reason, if you look at the spine, and again, we'll study this in detail next, is that in some areas, these spinous processes actually do what is referred to as shingling, where they are kind of pointing down and layered on top of each other. You can see that here. So they're not all sticking straight out. That's normal. And so that is part of, kind of just what makes a different space between them. Now, when we're massaging a person for this particular muscle, we don't spend so much time palpating all of these. This is just if you're being precise. What we normally feel is on this medial border of the scapula, and then we can feel the belly in here, which is a great time to transition to the insertions. And so again, it's a little bit of a false distinction between major and minor, and it really makes more sense to group them together. But if I was to start from the description on minor, which on this picture is on the bottom, I'm going to color it in right now. It's upper portion of the medial border of the scapula across from the spine of the scapula. So that's a good, landmark, right? If you palpate, obviously the spine is very palpable. So if you walk your fingers to where it points to, that's about how high we're talking about the rhomboids going to. And then we go down from there pretty much all the way to the bottom, except for the very tip. It's not at the very tip. So then with the description, we continue downward, medial border of the scapula between the spine of the scapula and the inferior angle. And all along this border, which as we know now is super palpable this whole way. And if we were to look at the fibers before we piece together what our movements are, as I mentioned, these are on an angle. And if we were to draw the left and right at the same time, the angle would be that of like evergreen tree. So we're angling like so. So of course, now we want to picture if we were to shorten the distance between the spine of the scapula and the spine, what would this do to the scapula? Adduct, right? So it's going to pull the scapula towards the spine, which is called adduction, and it has another name too. Retraction. So it's retraction or adduction. Now let's take into account the fiber direction, which again, I'm only going to put in minor just so I can hold on to it. But if we angle like so, and we shorten the distance between there and there on an angle, what else can we do to that scapula? Up, yep, it can elevate, beautiful. And then the one that's probably harder to see, that maybe harder to imagine, is if we kind of drilled something into it so it could rotate, it would rotate like this, which is downward.
Rotate down.
Yeah. So if I pull it like this, I'm just going to literally pull on it. If I literally pull on it like this, it's rotating in this way, which is downward. It's a little confusing about the upward and downward. I think what you can look at is what is the arm doing? So when I do that, the arm is going down. That's a downward rotation. Yes. Yep. Yep. Now, I mentioned this before, but now it should be coming together more and more as we're kind of looking at more and more muscles. Since this should adduct or retract the scapula, and many of us are slumped forward with our scapula too far forward, that means that our rhomboids are stretched, long, and weak. And so we need to strengthen them. We don't need to stretch them even further. So when we're massaging somebody, we do not want to pull even more in this direction, right? So there may be other tight issues like up here. We're going to talk about levator scapula next. And so we can be specific or if there's trigger points, we can release the trigger point. So it's not that we're not touching this area. We just don't want to stretch this area even further. And Chris brought up over break, you know, if the scapula is winged and already sticking up, we also don't want to keep pulling it out even more, right? It's already sticking up, and we'll get to serratus anterior next week is weak in that case. So we want to bring that back down. Now, muscles can cause us pain or soreness even when they're stretched and weak. And the rhomboids are a great example of this because many of your clients will complain about pain in the middle of their back. But when you observe their posture, you'll notice that their shoulders are not sitting, their ears and shoulders are not lined up and their shoulders are not back. They're actually rolling their shoulders forward for phones and laptops and everything else. So their rhomboids are actually long and weak. What other muscle fibers are right here in the middle that are also stretched out? Trapezius, yeah. Beautiful question. So the traps and the rhomboids are long and weak in most cases. And so how do you work with them, right? We don't want to stretch them out even more. We can do a couple things. We want to do more, release the trigger points. And in this case, that's going to be right on the border. So we can work up and down on the border, and we can work more cross fiber in this direction and not lengthening. So we're not going to do a lot of myofascial release in this direction. We're not going to do a lot of linear friction. We're not going to do a lot of stretching. We're going to do a lot of petrissage, tapotement, cross fiber friction release, compression, and then we want them to actually fire their muscles. So they are going to use their muscles to pull their arms back in retraction. One activity I see is to have them hold as if they're holding a medicine ball and roll their shoulders backwards. Rowing and all kind of backwards motions are helpful to get a full retraction, because until they learn how to activate those muscles, it's very tricky. You can give them an exercise like that, and it can be very tricky for them to understand in their body how to even use the muscles if those ones are not usually activated. So it takes time. But we want to activate those sleepy muscles. Yes. Okay, I'm sorry. Can I say one more thing? And in that case, because you were asking then, we also want to stretch and lengthen the ones that are the ones too short. So we stretch these and we activate the long ones. Or, yeah. Yep, go ahead.
That's literally what I was going to say. That we probably, that the text are probably tight and that we need to really work on.
The one second patch is here.
Yep, exactly. And lots of the long techniques work, and also we'll learn myofascial release, which is great for that.
So with the text so far, like we've seen pushing on them, maybe with the hip and maybe even like a soft fist. Has there been any other techniques that we've really learned?
We learned pin and stretch already in the pecs too. Yep.
I don't feel super confident with some of it.
That's okay. You just got an introduction to it. We'll do more pin and stretch. All right, so any questions about the rhomboids? This is a super common area that your clients will come in and say they're sore there, right? And then you want to look at their posture, and they probably have trigger points. And so this is, you know, the trigger points for the rhomboids are going to live right here along the border. And there we go. Let's get our rhomboids happier, yes?
Would it be obvious if they're like damaged and so the rhomboids like you know, the white part that connects to the spine?
Oh, the tendon?
Yeah.
Yeah.
I
I don't see the tendon, like I haven't heard too much about like a tendon tear on those. Yeah, it tends to be more the muscle on this one. Great question. All right. So these are very easy to palpate. Here's a great drawing on the left here with our origin and, our origin on the spinous processes and our insertion on the medial border. And again, we can keep that straight, right, about which is the origin and which is the insertion, right, because the origin is less movable. And the spine is not going to move as much in relationship to the scapula, right? We're going to pull the scapula towards the spine, not so much the spine to the scapula. And I should make this clear, the muscle is not saying, let's pull in this direction. No, the muscle's just shortening, right? But one side is more stable than the other. So it's just pulling in both directions, but one side is more stable. Does that make sense? Sure. Okay, super palpable. It's deep to the traps, but very easy to feel. I'd say the biggest sort of kind of palpation tip here is that, for fiber direction, if the fibers are tight, if we palpate on a perpendicular angle against them, it's easier to feel the little ropey fibers. But the traps are so thin in that area that even if you do not feel individual fibers, but you are in this area, you are doing the right thing, right? Even if you can't tell for sure, is that a fiber? That's all right. You're still on the rhomboids. All right, I think we have just one more today. But since we know some more of these muscle friends, let's take a look at the ones for synergists that we do know. So our rhomboids elevate the scapula because of that angle. And we also know that the upper traps do that. I'm just going to call out the ones we've studied so far and not the ones that we have not. All right, so I think we only have one more muscle today. So let's get through that last one before we take our lunch break. And then when we get back from lunch, we'll do the more sculpting and drawing. And also, now that we're farther along, there's some other review activities we can play together. All right, Levator Scapula. All your clients' Levator Scapulas are going to be jacked up. Haha. Yep. I don't know. Text me if you ever have somebody who isn't. Okay, Levator Scapula. This is a really cool muscle and it gets tight on everybody. So Levator Scapula, let's start OIA. Origin in red. Transverse processes of the 1st through 4th cervical vertebra. The transverse process is just a part sticking out on the sides. And if I was looking at a big model, it would be these parts sticking out on the sides. And now I'm going to do that up close for our little camera. So transverse processes. And some are easier to palpate than others. This is not the easiest sitting in the classroom activity, so we'll do this later. It's a little bit harder to feel these, but they are palpable. So it says the first through 4th. So just pop down 1, 2, 3, 4. Then we have these fibers that come down. They're very distinct fibers, and they go insert on the medial border of the scapula between the superior angle, remember is this top part here, and the superior portion of the spine of the scapula. So our insertion is right here. And you may notice in this top drawing that the fibers twist or rotate. And if I may take a moment to try to explain and draw how that happens, our origin of C1 goes down to the base in purple. And then our C2 attaches a little higher than that. And now in green, our C3 attaches a little higher than that. And then in orange, our C4 attaches a little higher than that. So that's what causes the twisting. And I call that out because that just helps with some of the upward, with the rotation movement, the downward rotation movement, excuse me. So on this model right here, it's this portion right here where the levator scapula inserts. And one of the reasons I bring up the twisting of the levator scapula is that it'll also make it feel very knotted and bulky right here. So everybody's going to feel knotted and bulky right there. They do also get very commonly trigger points there. And you know, this is a spot that I'll teach you how, when the client is face up, to really isolate this angle. And then you can be very precise starting here with your levator scapula and following those fibers directly up to the transverse processes. Whereas by comparison, what a lot of massage therapists do is they just try to come down like this and very imprecisely just try to attack this area. And there's a lot of bulky muscle in there and it can be hard to isolate it. So I'll teach you a way to be very precise and isolate this in a way that you can follow those fibers up. So important stuff. It's going to help your clients a lot.
Right next to the supraspinatus, so there's a tendon in between. I'm trying to see a picture of both of them.
It's close to it, but the levator scapula is kind of more, yeah, on the side, and then supraspinatus is in here. They're close, yeah. Yep, they're close. And
not any overlap. Is there any tendon or anything in between? Or no?
I'm not sure if there's tendon in between, but they're definitely like close enough that connective tissue could get them bound up together. Kind of like the anterior deltoid and pecs, how they should be separate, but they can get stuck together.
So that's a good place for some insertions. You want to be more careful with the deltoid insertion.
Yep. Yep.
And so the that one is a different.
Excellent. Yep, exactly. This is a very good insertion to work on for almost everybody. Yep. All right, and so then I already drew the fibers on this one. So if we take a look at that, you know, if we're attaching from here up to the spine, some of our actions, you know, if we pull the distance, this one's not quite long enough, but if we pull the distance between here and here, and we shorten that, we can go, what's this? Elevate scapula, excellent. We can pull it this way, arm goes down, what's that called? Downward rotation, excellent. If we pull the head this way, what's that called? Lateral flexion, beautiful. And then also if we pull the head to the same side, lateral rotation to the same side. So that's all its actions, one side at a time. That's called unilaterally. Bilaterally, if you fire the left and the right at the same time and both sides contract, we can extend the head and neck. So a lot of things that levator scapula can do, and probably the main reason why it's tight on so many people is because of that elevation function, because a lot of us, when we're stressed out, we hold a lot of tension upwards in our shoulders. So questions on our levator scapula? I guess I want to say one more thing here before we look at any other great pictures, is just that, you know, Anna already called out that this insertion is a great place to massage, and that is very, very true. I will teach you a precise way to do it that's exciting and beautiful. Basically, I'll try to show you with this skeleton, this model here is if my person was face up, I'm going to take the inferior angle of their scapula and I'm going to use it. And when I pull it up towards me, that makes this part stick out, the superior angle. So I use this to pull up. This makes this come out, and then I can get very, very precisely right on it and not get all hung up in all the other muscles. And then I trace those fibers exactly how they go. And it's a beautiful way to be precise with that muscle. All of these TVPs are palpable, but there's so much tightness in here that it works better to palpate inferior border up rather than the other way around. So if you follow it very precisely up, you can release it really well. And a lot of massage therapists, I would say, kind of focus too much right up in here and forget, you know, how it attaches to the neck. Question? Yes. Mm-hmm. I'll teach you that in the lab. Yep. Also, yes.
So when doing lateral action,
Yep.
then I feel these at the top.
Uh-huh. Good. Excellent. Good job. All right, let's just see any last pictures here. We should be almost done here for new muscles today. See what other goodness we have here, what other goodies. This view, you know, is going to be more helpful to you, I think, as you know more. This bottom view, you know, shows you all the other muscles in the vicinity, but we haven't studied a lot of these yet. So I think this one here is make a little more sense later. This we already got precise with, and that twisting. And so our elevation, you now know all of the muscles that are synergists in elevation of the scapula. We've got our upper fibers of our traps. We've got our rhomboids, and we've got our levators. So you know the trifecta there of our elevators. And so when you see somebody's shoulders that are all jacked up, you know all three muscles to work with. We'll also learn how to work with the fascia, but as far as the muscles. For our downward rotation, you know, 2 out of the 3 now are rhomboids and our levator. And there we go, let's call that. All right, so just to kind of share some sculpting here in the kind of red or orange is supraspinatus, originating in the supraspinous fossa, so above the spine of the scapula, and then going under that acromion process, so through that tunnel to attach out to the tubercle there, greater tubercle. So remembering that's out on the lateral bump on the shoulder. Infraspinatus is in pink here. It's got the big bulky muscles. You can kind of see that. And then it's attaching out to the greater tubercle as well. And the clay got a little bit smeary, but they are sitting next to each other. So we have supra, then infra, then teres, and it's deep here to infra. So I'm going to remove that again. So in blue here, you know, tucked up from the upper part of the lateral border of the scapula, and then it inserts on also the greater tubercle, but it's a little lower than the supra and infra. We'll put this infra back, infraspinatus, back in here. And then on the anterior surface in the subscapular fossa, here we have in purple subscapularis, and it wraps around the medial aspect and on the lesser tubercle. So on this model, the lesser tubercle and the greater tubercle are sort of exaggerated or emphasized with a big bicipital groove between them, and your model might not have that exaggerated quite as much. Okay, so here in blue I have rhomboids, and I have major and minor together because that's really how we massage them. You can't really feel a separation between major and minor, but the one that is higher up is minor, and the one that is lower down is major. So starting with the origin on the less mobile side is spinous processes of C7 and T1 is minor, and then T2, 3, 4, 5 is major, and that's really continuous on most folks. And then our insertion is on the medial border of the scapula. And if you go across from the spine of the scapula, which of course is very palpable, it's about at that level down to the inferior border of the scapula. And this of course is very palpable on that medial border. And then this rhomboid, major and minor, it angles up like so, which is useful when palpating to palpate against the direction or perpendicular to the fibers to feel them. As far as depth, these rhomboids are deep to trapezius and superficial to erector spinae. Questions on sculpting them?
I have a question.
All right, here's the last one I'm going to show, Levator Scapula. I had a hard time really getting the twisting showing, but the origin is the transverse process of C1, C2, C3, C4. And the biggest mistake I see folks do here is put it on the spinous process in the back. We don't want that. We want on the side on the transverse processes. So not on the back, that's spinous processes, but on the side. And then we want it to go down to the superior angle of the scapula. And if you sculpt all those fibers individually, you know, you can kind of show them twisting. So that's our levator scapula. And all of that is very palpable the whole way, which we'll learn how to do in lab.